thank you for letting me present to the group. I hope I raise some issues that you might find interesting, and I do like questions. I'll present, and then Dr. Vistoso will present the second half, and we'll take questions after that. Can you hear me in the back? I don't have a strong voice. Good, thank you. All right, AI and TMD, or facial pain. That's the formal title. The real title is, how can AI make us better diagnosticians? And the answer, from my view, is a highly structured note with point of care, algorithm assisted navigation. And I'll show you exactly what I mean by that. But let's go back to why. Why do you need this? And these are my colleagues and collaborators, Dr. Jerry Loeb from engineering, Dr. Vistoso, and Nicholas D.D.S, our data scientist. Why do we have to be better diagnosticians? The answer is, those patients that walk in might have any one of these conditions: salivary, headache, migraines, dysesthesias. And if you're going to figure out what's wrong with that patient, you have to know the phenotype, clinical presentation of all of them. And that's a big task. Just here's a few of them. So if I asked my resident, can you tell me the 5 or 8 features that define idiopathic condylar resorption? Might be able to do that. If I said, okay, tell me exactly what a patient with intracapsular adhesion has. What are the features that define that disease? On and on and on. They really can't do that. They can do some of that, but they can't do it for 100. Computers can. So what is the critical defining data, and why do we need it? And the answer is to be more accurate in figuring out what's wrong with our patient. That's why we need it. So my apologies to Charles Dickens. It's the cover of his book. And I changed it to A Tale of Two Hypotheses. So first one. Why do we need critical data? The phenotypic presentation of patients. Well, you don't need it unless if you don't mind being wrong, if you don't mind misdiagnosing and doing mistaken treatments, just fake it. You need the critical data to be accurate. Here's an example. New patients walking into a mental health clinic being screened by a professional mental health expert. How often were the missing critical data not present in the note? The answer was between 1/3 to 84% of the time. These are DSM-4 criteria. It's an older paper. And that's the actual paper. And where was it missing? It was missing on the things people didn't want to talk about: alcohol and drug use. The clinician didn't pursue it. The patient didn't want to talk about it, and the clinician didn't ask the right questions. You're going to be wrong if you don't get that data. My second hypothesis. Unstructured EMR data notes are inaccurate, and they often promote misdiagnosis. That's a pretty strong statement. We all, clinicians, all write our notes. We don't think we're wrong when we write those notes. So let's look at the basis for that. I say to you, it's a very big problem, unstructured EMR notes. And And the real bad actors are template notes. So, how often does a patient get a misdiagnosis? The answer is, it's well established, 14 to 17% of the time. That's 1 out of 6 patients. That's scary. That's scary. That comes from this paper, and it also comes from the Institute of Medicine's review. And I won't go into the details for that paper, but the percent, 14 to 17%, is pretty consistent. Now, how do we write our notes? Well, there's a lot of different ways. We sit with the patient, we listen to them, we ask questions, we write down some stuff, and later on we put it into our record. Sometimes we dictate it into our record. Sometimes we turn on our phone and let it record it and put the large language model note interpretation of what was said into our record. A bad principle is doing it at the end of the day. You see 14, 15 patients sometimes, and then you have to go and write your notes. At the end of the day, you can't tell the difference. You can't remember them. Your notes are not going to be accurate. The real bad actors are the template notes. Now, we use template notes in our clinic, and we do a pretty good job, but let me show you why I don't like them. Here's a template note right from our clinic. No, obviously identified. The yellow is what was actually typed by the resident. The blue was what was in the pre-written template. It was never changed. Maybe it didn't need to be changed because it was already accurate. Most of the blue is things that are missing. So here's the history of present illness, the chief complaint, a little bit on the medical history, some objective findings. Patient didn't have this, patient didn't have this, patient didn't have this. And if you checked on all those things, you don't need to change it. You go further down into the note, and again, a few data points we wrote in, and exam on into the psychological assessment and the image assessment. Here's the problem. Were the unchanged elements of our template note actually performed? Problem is, many times they are not performed, just carried over, cloned. Now, I say that with confidence. Why do I say it with confidence? Well, what happens if a patient examines the EMR note that they have in their record? And this was a study where they asked patients to look at their EMR notes. Your portal, you can see your note. And they answered a questionnaire. Was it accurate? 42% said there were serious errors. 9%, 10% almost, said those errors were very serious. That's a lot of mistakes. That's the patient's interpretation. Let's look at it in another way, and that's where the study comes from. The VA had the courage to do this study. They had a standardized patient actor, somebody who knew what the disease was and they could present with that disease. They surreptitiously recorded the encounter. The doctor did not know they were being recorded. And then they looked at the recording, standardized patient's notes that he wrote later, and they looked at the EMR. And they recorded 105 encounters. Not a trivial number, a good number of encounters. 181 of the EMR notes had findings that never occurred. They were cloned from the template. And there were 636 documentation errors. The actual conclusion of this courageous study is this bottom line. In fact, The medical record should not be assumed to actually reflect care delivered. Scary, absolutely scary, and courageous. Dr. Weiner, I've never met you, but you're my hero. So what are we doing for us to try to improve what we're doing? And the answer is we've created a structured note for the encounter, trying to guide it a little bit better. And we also have an outcome note, which Dr. Vistoso will talk about. Our app, which I'll show you now, is our point of care. Highly structured note with algorithm assistance. So what the heck is that? Well, we've been pioneering it and developing it for years now. There's algorithms embedded in the note, and I'll show you how that works. It predicts the diagnosis as you add data. The answers are all drawn from our data set. It's not from the internet. It's from our data set of cases that is drawing this. This one matches this group. And it's not a symptom checker. It's an encounter. Now, what's wrong with symptom checkers, since I mentioned that? This is a good study. It was just done recently, a couple of years ago. And what they looked at is people that did not have vested interest in the symptom checker, analyzing it. Now, if the company that built it analyzes it, there's vested interest, and you have to be worried about mistakes. And when you look at symptom checkers, there's no physical exam, it's just whatever the patient's pretty. The accuracy was in the 40% range. Most of the companies that funded studies said it was in the 80 to 90% better range, and it was always better than a clinician. Be wary. All right, so here's our dashboard. What is the real value of a highly structured point of care algorithm assisted note? And that is, it helps you collect the right data because it's structured. And it gives you information as it's being input to help you think about what it could be. That's the challenge every clinician faces. What is it? I'm going to show you a case, and this is a case. I just took some slides from a case. And a patient walks into our clinic, sits down. We record their sex, we record their age. Now, if you walk into our clinic, the odds are that you have a jaw muscle pain, you have a sore joint, or you have a clicking or popping joint, or you have some arthritis or some of the other less prevalent things. But these are the prevalence of conditions that walk in and sit in our chair before we know anything about them. Right, so I put in the, and by the way, this gives a case of a chronic toothache that didn't go away. First root canal, second root canal, third root canal, maybe the other tooth root canal, and it's still painful. This is what we would call a neuropathy. The odds are, if you come into our clinic, you have a 2.66% chance of having that condition. So what happens if I put this same data, age and sex, into Claude? This is, I don't know what it is. I now add more data. I say, okay, I have a map. I say it's the upper left quadrant. And I say it's the toothache. And now my probability prediction, which is in a sidebar, pops up chronic trigeminal neuralgia. If you walk into our clinic and you have a toothache that's been treated 3 or 4 times and it hasn't gotten better, the odds are that it's a neuropathy. Let me go beyond, but it's only 21% probability. Now, Claude would say odontogenic pain, but it could be dental decay or pulpitis. reasonable. I put in some more information, and here's a category of what it could be. It's not a headache, it's not an earache, it's not an abnormal structure, it's not a sleep disorder. I say it's probably a nerve disorder, it could still be a tooth problem. So I put in the category. Now the probabilities go up. 89, 83%. You know, people with acute draining abscesses don't walk into our clinic, or a chronic pain clinic, not an acute dental clinic. So in our clinic, based on our data, we know the probability pretty high. On Claude, the same exact data, failed endodontic treatment. Missed canal, obviously a new root canal is needed. Now, unfortunately, many clinicians would stop right there. Then they would repeat the root canal. Or they do an apical surgery, or they root canal another tooth, because obviously if this one was a good root canal, it must have been the other tooth, or they'd extract it. And that happens, we see it every day. But let's collect a little more data. Here's the history of present illness. It is a 5 out of 10 severity, it is continuous, it has been there for months, it is a dull aching pressure, it is unilateral. If I put that data in, and I also say it is a unilateral dental alveolar pain, has focal dental alveolar pain, it's been persistent for several months. And the patient is very sensitive to touch. Those are all unique features for neuropathies. And what happens? My probability goes up to 99%. I'm pretty sure what it is. I mean, as an expert, I knew that anyway, but the novice wouldn't know that. And I'm ready to make the diagnosis. And I go here to the list of categories of conditions. When I put that there, I get the phenotype, all the features that define this disease. And later on, I'm going to have these color-coded, so I know which ones I already asked and which ones I haven't asked, in case I want to increase the collection of the critical data. By the way, that's an example. I could show you others, but I won't. This information is being published probably this month, Annette?
Yes, yesterday.
Yesterday, okay. In the Journal of Dental Association, American Dental Association. And, you know, why do we do this? We want to reduce misdiagnosis. We want everything in our structured note to be immediately machine learning compatible. We have 1,000, actually 2,000 cases now of data. And we think this algorithm will provide guidance. And it's predicted from our data set and accuracy when we did 50 new cases, completely 10 different diagnoses. 45 out of the 50 were predicted the top answer every time, 93% probability. So where are we now? As I finish, we have 2,000 cases. I want 10,000. We have a naive Bayesian inference algorithm, and we're still tuning that algorithm. We're still working to make it better. You have to tune it. You cannot just accept it without tuning it. We have a transparent system. I know the effect of every single variable on that prediction. It's not a black box. It's not a large language model. We can see how each feature affects it. Our prediction is reasonably accurate and is being tuned. We have preliminary data, phenotypic data on 70 of oral facial pain conditions, 50 of oral medicine conditions. And we're now in the process of ranking the variables that's in our phenotypes so that we can understand the important variables. Having pain is not an important variable. All of our patients have pain. Having pain in a tooth that's been treated by an endodontist 3 or 4 times and still has pain, that's an important variable. That determines what it is, plus a bunch of other things, obviously. So in summary, we think structured data is needed. We think it should have point of care information that you provide to the clinician as they're collecting the data that hopefully is accurate. And as we collect outcome data, we should be able to not only diagnose better, but even treat better. And that's the end of my presentation. Thank you.
Right. So my second part of the job today is I started talking to you about like how we need structured data, and then we came up with the panel. Now Dr. Clark explained what is the system that we are using, but what happened with our patients? That's the third part that we are presenting today. So basically how we get the information from patients and how this is going to help with the patient-reported outcomes. So again, this is our research team. So let me just give 1 second. So we discussed about the phenotypic issue, how we can make the diagnosis better to address the misdiagnosis, how we can address the treatment plan. And that's this part, how we have limited evidence based on the treatment. So what is the question that we have right now to address the current TMD research gap that we have between the clinical guys and the information and the data? So basically how we can improve the treatment effectiveness. So what factors affect the TMD treatment impact outcomes across the different patients subgroup. How we can actually, we talked so much about personalized medicine, but how we can actually get to that point, and what are the most effective treatment strategies for different patients group. And then with platform, how we use it, what are the different tools we can use, how practically and effective this data collection can be applied in the clinical setting. So we are presenting another app, but this is not just an app presenting, it's these are the tools that we are using, and that's how we are in this area right now. These are actually the tools. So we presented some symptom checker with pre-encounter questionnaire, then how we in the clinical side, how we do the structure, the note-taking system with this highly structured machine learning compatible system. And these are all HIPAA compliant system, of course. And now, right now, I'm gonna talk to you about the post-visit questionnaire. What is the patient goals and how we get the patient information. So why patient-reported outcome it's important? Why we are doing this study? Well, because we need this real-world evidence that capture the patient experience in their daily life. Know what us clinician wanted to say. Know what us clinician wanted to ask. So what the patient actually want to say. This also measures what matters more for the patient. Patient pain reduction, for example, instead of, for example, maybe they don't want the exact or the accurate diagnosis, but they want the patient reduction. They want to have a more functional improvement and a better quality of life. And then how we can actually get to the personalized medicine, enable this matching of patient profile with the optimal treatment strategies. That's our goal. So what are the research, this is, of course, we're gonna generate research advancement, provide this longitudinal data, essential for understanding the disease, the progression, and most importantly, the treatment response. So we developed this patient outcome, reported outcome tracking system that is designed especially for this longitudinal TMD patient. The key feature that we decide in this app is mobile first design. This for everyone has a phone, a cell phone, and that's something that we, after some research, we analyzed that the demographic can go through like early 8 years old to a 90 years old, so we can have a wide range of demographic as a patient in a recruited patient. Real-time data capture. We have the weekly symptom tracking, so we want the patient to report every week at least, and how we can monitor the treatment response. That's part of the clinician. So the technical specific here has to be a HIPAA compliance, has to be a de-identified data, and have to be these weekly automated reminders, and of course need to have access to the clinician. So that's why we need the dashboard for the clinician. So what we have right now, what is the data, or what is the collection framework we have? We have 10 questions at the beginning, that is the quarterly baselines assessment, which we ask same question as I think Peter was talking a little bit about this in the phenotyping that they are using at UCSF. We are using similar assessment point, like depression, anxiety, stress, hopelessness, sleep quality, teeth grinding. So in total, 10 questions that patient answered at least once quarterly every 4 months. And the first one is at the first visit. And then we have weekly tracking, symptoms progression, how patients feel, how patients feel that the treatment is affecting or improving the quality of life, what are the side effects, what is the functional status in the patient, and all the things we are having that information weekly. Then we have the treatment specific efficacy, see if the medication is working, see if the rehabilitation treatment are working and which kind of rehabilitation, the office intervention also we incorporate in the app, diagnostic test, and a specialist referral. Right now, we did this pilot with 4 different categories of TMD, including the myofascial pain, the pain on the joint, internal derangement, degenerative joint disease like osteoarthritis, and associated conditions as headache, earache, and related symptoms. And these are the inclusion criteria symptoms that patients need to have in order for be enrolled in our study. So right now we start with our goal is to have a multi-site research network with 300 participants across 6 different clinical sites. So we know that this information cannot be just from our demographic. Our demographic specifically in our clinic is like 80% of Hispanic population, between like 25 to 60 years old. So we need more like a broad representation of patients. So that's why we partner with recruitment clinics from New York, California, Utah, Washington, and Arizona. So in this way, we have a geographic diversity with urban and rural population. We have a diverse socioeconomic background and multiple treatment approach as well, not just the thing that we think that we need to do for patients. So how this start? Start with the recruitment clinic, the clinician recruit the patient, introduce the app to the patient, but it's basically, again, not like an app base. It has to be like how we can give you some answers and how we can monitor you when we are not seeing you during this 6 weeks, 8 weeks, or probably 3 months between one visit and the second visit. Then patient need to sign informed consent. The time that patient signed informed consent, we also give the patient the key, that is the identification of the patient. So that's the way that we are having the identified data linked to that patient. Then we have a baseline complete initial assessment. That is the 10 question as you saw. We try to use it like very user friendly to for every patient. I know that probably in the images you see very little and small numbers, but we are improving that. That's all the part that how patient can know how much to put the number and evaluate each of these questions. So something that is easy for everybody to actually answer. And then if patient rate any of these questions 5 or higher, will trigger a more detailed multi-item brief questionnaire that will be this all validated questionnaire. And then every week, with patient will have a notification to track their symptoms. And very easy question, like how you feel, how is the treatment, how is the pain today, is the medication working for you, it's too early to say, have any side effect. And the good thing is the clinician can actually see these answers. So ask me, this is my patient, for example, this is one of my patients, and I can see how many times the patient is answering the question and how patient is feeling. We also have this in different language because we have a huge population, Hispanic population and Chinese population. So we have the ability to change the language. So the good thing is the clinician also is tracking the patient, and you can intervene earlier in how patient is feeling. The other thing that is very, very important for us as clinician and researcher, I'm proudly saying that yes, we are researching in our way, that we can actually analyze data. This all data is de-identified for me as a researcher. It's different when I'm clinician in the site. When I'm clinician, I have the data from my patient, but when I'm in the part of the researcher, all this information is de-identified. And as you see, we can create this radar chart when we can actually see how patient is feeling. We can give some information to the clinician how to approach patient, how to intervene the patient. If, for example, patient is feeling like the access of care is something that is very important and their outcome, or if the patient is too worried, or if patient is not distressed. So this will help us again to see what is the prediction of this patient, how this patient is going to tolerate the treatment. And this is what actually Peter was explaining much better and with all the graphics. So I'm great that he presented before me. So these are the latent profile analysis. So it's basically predicting the treatment success of our patient. It's just we're using a different data. Not all with all the serology and biomarkers, because we don't have in these patients, but we do have the person-centered approach. That is this next level. Dr. Gara did a pioneer study in 1993 about the same thing, how we can improve, how we can define these subgroups. And now we have, with enough data of this confounder information, we can identify this latent profile analysis of our patient and suggest, for example, in these cases that I showed you before, this is an example of an analysis. For example, this patient presents moderate emotional distress, has a high catastrophizing, or has moderate pain, and has reasonable motivation and healthcare access. So that's how can I intervene as a clinician. And we can give the patient some recommendations. For example, maybe this patient needs an early psychosocial intervention instead to wait until patient is like devastated or depressed and it's very hard to approach the patient. Or consider, for example, alternative treatment as CBT, cognitive behavioral therapy. Or actually this patient needs more medication or a different medication or a different approach. So what is the value of all this information for you guys, for the repository? Well, we can standardize this data collection. We can consistent metric across multiple site and patient information. We can have this longitudinal tracking, real-time disease progression. And that's what I think one of the questions that we came in during the panel. We actually need that time progression and treatment response and real-time updated. A scalable infrastructure, like platform designed for expansion to larger patient cohort, and of course has this interoperability, data structure for integration with existing research database. That's the point. So we really think that this standardized data set can contribute to national TMD research initiative and meta-analysis. We can have this real-time monitoring to our patients. We can create and we can analyze this latent profile analysis. We can modify the treatment for our patient in real time, like intervention at the time patient needed, not 2 months later, or when I see the patient. We can actually have risk stratification. We can early identify if the patient is likely to fail, how we can intervene before the failure, and how we can, for example, ask for additional treatment or alternative treatment. We can actually integrate machine learning to enhance this phenotype discovery with AI-driven pattern recognition. And finally, we can have this pattern recognition for treatment success. That as a clinician is like very, very important. This is how what is driven our research. So what is the future impact? Immediate benefit, reduce the clinic visit frequency for patients that are stable. Probably I can see the patient in 6 months if patient is feeling well, and I can communicate with them through the app. Or we can have an early intervention for patients that they're not responding to the treatment. And the evidence-based treatment selection. And that's something that as a clinician and researcher at the same time, when I present this option to the patient, they all want to be enrolled because they want to have this information available to them. The long-term vision is integration with EHR system, expansion to other orofacial pain conditions, not just the 4 categories that I present, and of course, other fields, not just orofacial pain. Multi-institutional research network, AI-powered treatment and recommendation, because that's what we are dealing with, this amount and huge information with AI, and input data FaceBase to contribute to other clinicians as well. Thank you.
So first of all, I just want to read a comment from Dr. Webster-Syriac. Actually, I think it was right after Dr. Clark's part of the talk. Has this Bayesian algorithm been tested in a teledentistry format? Do you see differences compared to clinical interactions, compared with clinical interactions?
Has it been tested relative to what?
In a teledentistry format.
Teledentistry.
The reason I bring it up is because, you know, this is such a broad disease and many people do not have access to oral facial pain experts. So I'm wondering about expansion to individuals who may not be able to be seen in a clinical format.
Sure.
To help with primary care folks.
Thank you. Of course, teledentistry does not allow physical examination. And we think that physical examination is an integral and important part of making a diagnosis. Simply taking the patient's story and deciding what it is without examining them is limiting. Now, if you look at the paper that's just published, you're going to see a graph for our 10 diagnoses we tested. And we put on the bottom of the graph chief complaint, history of present illness, extra questions, physical exam features. And as you gather that data, some conditions like trigeminal neuralgia go up right away with the history. And there's nothing in the physical exam that proves it's trigeminal neuralgia. You're just ruling out other things. So there are certain diagnoses that the telehealth consult could easily help with, but there are certain things it can't help with because you don't have a physical exam. Did I answer your question fully?
Yes, I have two other quick things. One, I think that could be really helpful for clinical decision-making and then referral to their closest potential provider.
Yes.
Just because of the so many who are not getting care. I did want to ask on the second talk, I think this TMD specifically is such a heterogeneous disease. And so I believe that the standard data could help with refining the phenotypes. As we know, people may respond differently to different medications or treatments because TMD is not a one size fits all. So I'm just wondering, have you started to see within the standardized data, different phenotypes start to shake out?
I'll answer it. Show that if you can. We need to collect more data to get computational phenotypes. Right now, what we have is a combination or hybrid of expert opinion phenotypes and our small data set validating those expert opinion. Now, they're pretty close, but really in the long run, we need computational phenotypes for the myriad of conditions we deal with. And we don't have enough data to predict. Now, here's that graph I was showing you. And demographics, interview where it hurts, the category, the history of present illness, extra questions. And now we start exam. What you can see is that some diagnoses, burning mouth syndrome, and trigeminal neuralgia, we didn't need to do the exam because there is nothing to find on the exam. They exist without physical evidence of lesions or other things, but some of the conditions did not rise up until you did the physical exam. And now we're in the high probability range. So You can't just do it with a symptom checker. You can't just do it with a telehealth consult. It's probably better than a symptom checker, but you need the exam for a lot of problems. I don't know if that answers the question. I'm sort of got lost in the answer.
No, I think it's great, and congratulations on these efforts. I look forward to seeing them move forward.
Thank you. Thank you.
Great, thank you.